So guys, thanks for coming. My name's Patrick Moss. I'm one of the vice presidents of LifeLink Anesthesia. I'm also a proud director of the LifeLink education arm, which is known as LifeLink Academy. So we do a lot of internal education. We have a cadaver lab at least once a year. This year it's going to be at UT Chattanooga School of Physical Therapy, June 14th. You'll be getting more information via email about that, how to sign up if you're interested, but it's an all-day cadaver and live model needling. What I'd like to focus on is what you're currently doing, and I see a lot of orthopedists on your schedule. So I'd like to really concentrate on limbs, and we can do a little bit of trunk if you want to, but I can always come back and add to it, all right? So I'll kind of let you guys direct me on what you need based on your patient population, of which you know much better than I do, all right? So a couple of principles that I need you to know. In order to optimize the image that you see, there is an acronym called PART, P-A-R-R-T, and it stands for adequate pressure, alignment is not jumping in spots, but it's maintaining application to your patient and moving it in this kind of direction. So if I ask you to align laterally, I'm wanting you to do this. Align cranially, I want you to do this. Does that make sense? All right. Rotate is like this, and you would utilize rotation if you've got your needle and I'm only seeing a portion of it. So if there's anything that you remember after having this little discussion, it's if you don't see the tip, please don't advance your needle. All right? You need to maintain control of your needle tip at all times. And the person who is assisting you in administering the either hydrolocant or the local anesthetic is just as important as the individual that's driving the needle. They can create space for you like an icebreaker ship does on the sea. So they can part things for you and you can actually drive around those with your needle. So again, pressure, alignment, rotation. The next one is rocking. And today we utilize rocking in, when you rock, let's say your needle is here. You can rock it and make this footprint parallel to your needle. That equals perfect reflection. If your angle of inclination, meaning your angle that your needle has entered, is much more obtuse and you're not as inline or parallel with your footprint, your energy comes down and gets refracted, and that's when you have real difficulty in seeing your needle, okay? And then the last one, pressure, alignment, rotation, rock, and tilt. And one of the most common errors that regional novices make is they just want to tilt in order to see their needle. If you can imagine a paint stroke, kind of like this, that's what you want to be doing with your probe. And then as you see the reflection of the needle, then you can slow down and begin to tilt. But not until you see that change in echogenicity that the needle creates on your screen do you want to stop alignment. Don't just get fixed and tilt. You want to kind of do this, and then when you dial it in, anybody remember the old radios that had the dial? Remember how you'd go down and then you'd hear it, and you'd slow down and then really dial it in? That's what you're doing with your probe. All right, everybody got the PART acronym? Pressure, alignment, rotation, rock, and tilt. Those are the only 5 maneuvers that are universally acknowledged by ultrasonographers. All right, so if you don't have a good image on your screen, it's because of one of those 5 things. All right, now let's talk about 2 other principles. All right, alignment and axis, plane and axis. If this is my needle, and I'll show you on here, you can see that this would be in plane, all right? So if your needle enters and you're looking at the shaft and the tip, that is in plane. Plane refers to your probe's orientation to your needle. In plane, 95% of your regional anesthetic peripheral nerve blocks are going to be done in plane versus out of plane. Almost all of your vascular punctures are going to be done out of plane. Out of plane accessing the radial artery, out of plane accessing the internal jugular, out of plane accessing the femoral. Now the one time that I would want you to go where you can turn this and look at your central line in plane is looking at your J wire before you dilate. So you have your introducer in out of plane. You disconnect your syringe and you go to thread your wire. Once you thread your wire, take your probe, which is out of plane, and rotate it so that you can see your J-wire within both walls of the internal jugular, because your J-wire can go through the posterior wall, and then depending on what size your dilator is, you can dilate all the way into the chest. All right? So, in plane, out of plane. Most everything we are going to do is in plane. Plane is probe's orientation to your needle. Everybody got that? Now let's talk about axis. Axis is probe's orientation to your target. So if you can imagine the brachial plexus coming off here, we are looking at a transverse view or short axis versus long axis if I were to rotate my probe in this direction. Does that make sense to everyone? If you can imagine my median nerve is traveling down my forearm, I'm looking at it in long axis. Now I'm transverse short axis. Does that make sense? So most of your peripheral nerve blocks are going to be done in plane, short axis. For an example, supraclavicular, in plane, short axis. And it'll make sense when you scan a little bit more, okay? Everybody got those two things? All right. We're going to get to scanning here in just a second. I just want a couple more foundational points for you. Since you really don't have a great deal of experience with sonographic regional anesthesia, if you don't have a good understanding of the actual sonoanatomy, please use your color button. Both of these have them. And just hold still and make sure that in your field there are no vessels. And then over time, as you begin to hone your expertise in regional anesthesia, you need to get on NYSORA. There are all kinds of websites that I can share with you guys so that you can understand they're not aberrant vessels. Those vessels exist on the majority of patients, and you need to be aware of them. For those of you that have played Monopoly, you might know the green Pennsylvania, North Carolina Avenue, and then as you come on down, you get to Boardwalk and Park Place. Anything above the clavicle are those properties. This is high-priced real estate. You can really harm some people if you're not careful up here, especially if you don't see your needle. So don't advance unless you see the tip of your needle. All right? That makes sense? Now, I'm going to teach you also blocks below the clavicle, and the infraclavicular and axillary are excellent for your patient populations. We probably won't do femoral today. We'll do adductor canal, and for ankle fractures and arthrodesis of ankles and things like that, I can show you popliteal. All right? When it comes to local anesthetics, guys, there are really only 3 reasons that we're providing this regional anesthesia. It's either anesthesia, which is you're going to utilize that block as your sole anesthetic, or it's analgesia. In conjunction with your regional anesthetic, you're going to utilize something else, a general anesthetic most probably. For instance, a shoulder arthroscopy. You do a single shot and then you put them to sleep in the back, correct? And then the other is both. So let's say someone is undergoing a very painful procedure, you're going to send them home with a continuous catheter or upstairs to the floor with a continuous catheter, and you're going to utilize that as your sole anesthetic, then you're going to continue it post-operatively. So you need to decide why you're doing this, all right? If you're leaning more towards the sole anesthetic, your concentration of local needs to increase because you're going to need as much potency as possible as it serves as the sole anesthetic. If you're using it as an analgesic, you need to limit your concentration because it's not serving as the sole anesthetic. It doesn't have to be perfect. So don't worry about dumping 30 cc's above the clavicle when 12 works just fine. Your goal is to get them home safely, comfortably, without having dyspnea and hoarseness and all the other things that come with Horner syndrome and stellate ganglion blocks. That makes sense? So choose your drug wisely. Ropivacaine is excellent above the clavicle. I almost always use ropivacaine, and I never go above 20 cc's. I always watch my spread. Once my spread not encompasses the brachial plexus, but once I've got plenty of spread on the lateral aspect, I stop because they're going to be comfortable intraoperatively and they're going to be comfortable going home transitioning to PO therapy. All right? Truncal blocks such as tap blocks, erector spiner, anything semispinalis blocks, all those you're going to minimize your concentration of local because they are volume dependent. All right. Tap blocks, I routinely put 40 or 50 per side. Erector spinae, I routinely put 20 or 30 per side. All right. Regional, if you're below the clavicle, you can go 30 easily. But remember, there's a 100% chance that you're going to have some degree of phrenic nerve palsy, and 10% of that population is going to be symptomatic. You're 28% when you come down to the supraclavicular block, so you decrease it dramatically, which is why I almost never do interscalenes anymore. All shoulders for me that aren't getting a catheter get single shot supraclavicular blocks, and they work just fine. They're excellent, even posterior coverage. So I can show you guys where the dorsal scapular peels off, and you can stop right there and deposit local at the supraclavicular level and get the dorsal scapular. All right?
Does that cover your puncture sites too?
Absolutely. And another thing, anytime I have leftover local anesthetic, I take it in the room and dump it on the surgical tech's back table in one of their little stainless steel cups, and I ask the surgeon to inject all of his sites and his incision, even with my block. Over the next couple of hours after your block, you've got systemic uptake, and the chance of local systemic toxicity is extremely rare. I've done it for years. So put your surgeons to work. Don't waste local anesthetic. It's kind of like alcohol. You know, that's a party foul, man, if you drop that stuff, right? So we're going to need 2 individuals. What we'll do is we'll work from the top down, and we'll just continue scanning. And guys, I'm here as long as you want to be here. All right? So if one more person, you what?
Me. I'm the other person.
Toby, correct?
Yes.
So
Yes.
come over here and have a
Okay.
seat, and I promise you'll learn just as much as everybody else. So we're going to start out with interscalene. So when you lay down, what I want you to do is I want you to lay down with your head here so that you can see this.
Okay.
All right, because you're going to learn a lot while people. We probably need several washcloths. Where do we get those?
Got it.
All right. So, ma'am, if you will, can you take off your jacket? I don't want to get that dirty, and I'm going to keep you clean here, okay? And what you're going to do is you're going to rotate your head looking at this screen.
Okay.
So we'll do above the clavicle first on everyone. Once everyone's comfortable with that, we'll move to below the clavicle. Once you're good with that, we'll go to the lower extremity. After that, we'll do truncal. We'll be out. All right? And again, Brian, you get me a thumb drive, and I'll dump 7 gigs on for you.
Perfect.
Okay?
I'll get it to
And
you.
it's loaded with videos.
Awesome.
All right, so I am going to protect you. So if you will, I'm going to move this all the way. Another thing is positioning patients. It matters, all right? So not so much with single shots, but guys, if you get to the point where you're doing catheters, turn your pillow kind of like this and have the patient lay on half of it and turn your head all the way. And I tell them, if you're comfortable, you're in the wrong position, all right? This isn't intended for comfort. And a lot of times I'll have the rail up and they'll scoot towards the side, and I'll put a pillow right here on the side of them so that they're kind of turned, because you're coming through the trapezius, posterior approach to the interscalene. And that way your catheter is out of the surgical field. But if you're doing single shots, it doesn't matter. You just need space up here. What is your name?
Anna.
Anna, I'm Patrick. I really appreciate you volunteering. It's a big deal to us. So I'm going to cover you, and I'm going to prevent you from getting really wet, okay?
Okay.
And I'll cover the space too. Are you okay with that?
Mhm.
I'm going to keep your hair here. So guys, if y'all just step up, I'll put a probe in somebody's hand and we'll get started. The first thing that you're going to do is determine laterality, all right? In your mind, you need to decide how you're going to enter this particular screen. And so if I'm on the right side of the patient's body, I like seeing my needle come in from the right side. But it doesn't matter which way it is. You just need to understand it. I typically will stand in the patient's pit. I'll put all of my instruments above me. I'll have the monitor up here with whoever's assisting me, handling the monitor, pulse ox, all that kind of stuff. You need ASA standard monitors. Don't skip any steps. Put your ECG monitors on. Anybody seen the last event here? Has it occurred? Does everybody know where your lipids are?
We're actually working with Allie on getting them up here in these 2 rooms. in our
Absolutely
cart.
fantastic. You want to have easy access to them. All right. So the new 2015 Regional Anesthesia and Pain Medicine Guidelines for Local Anesthetic Systemic Toxicity came out. don't think, give 100 milliliters. All right, this is on general population, not pediatrics. Okay, just as fast as you can get it in. All right, I've seen it once, and we've had one of our sites that had it, went to the Plexus to get it out, and the pharmacy tech didn't replete it. Patients had their seizing. So know where your stuff is, just like your crash cart each day. Know where it is. All right, so for Anna here, you can tell that she is extremely thin, and anything above the clavicle is going to be, as far as the surface goes, it's going to be shallow, okay?
Go off.
Oh, sorry.
I think we're good.
Thanks, Eric.
Yep.
Anna, you're going to learn a lot here. You're going to want to go home and start blocking stuff. The best thing to practice on, guys, is pork shoulders. They're about 20 bucks. But every month we have our new rotation of regional anesthesia students come in from the Middle Tennessee School of Anesthesia, and I bring a pork shoulder every first of the month. And I have them sit there for hours and just needle that until they hone their hand-eye coordination and they understand how to maintain visualization of their target and their needle at the same time. You're going to find that it's going to be easy to find the right target on her, but when you introduce another variable, it's difficult to keep your target and your needle because you're always wanting to find your needle. Now your target's gone. That's the most difficult part. Split a pork shoulder. Go ahead and buy some barbecue sauce. You guys come in here and just inject it up and then take it home and smoke it. All right? So I want to know laterality. The best way to do it is just to touch your probe. I want right to be lateral. Okay? So when I touch it, you can see left is what I'm touching. I want right. So when you apply it to the patient, you want to apply it with the correct side. So if I'm doing this, I'm starting in her pit. I've got everything that I need right here. My gloves are sterile. I've already prepped her with ChlorPrep. And you want to begin midway between the supraclavicular fossa and the AC. All right? Once you place it there, you don't want to look through her neck. You want to look down into her chest behind, retroclavicularly. When you do, you want to hold still, and you need to have the adequate depth. If I had 2 and hers is 3, I would never see it. And it's frustrating when you're looking for it, and it's never going to be there. So have adequate depth and adequate gain. And we adjusted our gain today. Gain attenuates for loss of energy through media. And so the further the energy goes through the media, the less the energy is by the time it gets through the media. You can adjust that brightness or gain depending on what you want to see. So halfway between, right here, I'm going to look down into her chest and I'm going to hold still. Everybody see the supra or subclavian? All right, now, can you hit freeze for me? It's the upper green button. Okay, so in this picture, wait right here. Don't move.
I'm gonna take some needles to Demos after this and eat some food and poke around on.
Why is this guy stabbing us?
That's why this guy stabbed his pork with needles in.
He wants to do it with a raw pork shoulder. Well, we'll trade off.
That's right.
We'll inject all your shoulders.
All right,
You'll feel
so
the
There
in
you
this
go.
picture, guys, you can see the subclavian artery. It was pulsatile if we turned on color. It would be blue if the flow was going away from the probe. It would